first presentation is by Dr. Abhishek Sachdeva. He is MD DNB, Professor MLN Medical College Allahabad. He will present on guidelines ESC versus ACC hypertension guideline.
A very good morning to respected chairpersons. Uh, at the onset, I would like to thank Dr. Alok sirs and congratulate him for achieving such a great milestone in the field of cardiology. So today I would be talking about ESC versus ACC hypertension guidelines key takeaways. First of all, we just getting into a glimpse of ACC 2017 versus ESC 2018. ACC defined normal BP as less than 120/80 and ESC were more on a liberal side, and they took into consideration elevated blood pressure, and they classified hypertension into stage 1 and stage 2. On the other hand, ESC 2018, they classified, they didn't use the word elevated, they used high, normal and stages of hypertension. According to this, the 2017 and ESC guideline, they decided the treatment plan, and the target BP depends on the ASCVD risk greater than 10% risk, class 1 indication for treatment in ACC guidelines, and ESC were more like a individual tailor-made approach and depended on the age of the patient also for treatment. So now coming to the ACC 2025 guidelines, they have classified again continued the same as normal and elevated blood pressure. Stage 1 is 130 to 139 millimeters of mercury and stage with a diastolic or 80 to 89, and stage 2 is greater than 140/90 is the stage 2. European Society took consideration of office and more laid stress more on home ABPM and 24-hour ABPM. Considering the office blood pressure, non-elevated blood pressure less than 120/70 is considered to be normal. Elevated, they have a wide range up to 140/90, and once patient having a BP greater than 140/90, they have to be treated as hypertensive. So if you talk about the consideration, the new contenders, I would say that the ACC officially retires and replaces the landmark 2017 guidelines. On the other hand, the ESC guideline updated the 2018 ESC guidelines. So both the guidelines had major updates on risk assessments. The ACC used the prevent score and ESC used the score 2. They have a treatment targets, and for the first time formally included new device based therapies like renal denervation. In a nutshell, if I would like to summarize, I would say that the ACC guideline was more intervention based, and it was basically trying to treat more high risk individuals, and European Society was more comprehensive, prioritizing individual therapy and avoiding over treatment. So that was the main game. So the key battlegrounds between the two guidelines, the definition, one says less than 130/80 or greater than 130/80 is hypertension, and other says more than 140/90. And again the risk battle, one used prevent score, other used score 2. Though most of the data actually has been derived from the sprint trial, but they have analyzed it differently. The target is different. Europeans have, though they have just, I would say, they have sprinted out the sprint trial, and the targets have been little bit elevated. They say go low if the patient is comfortable, and again this is very good. The strategy, at least now they both converge on the one. They go for single pill combination, and renal denervation in these guidelines have made the inroads, and primary aldosterone screening is another aspect which both the guidelines stresses on. So if you see ACC 2025 more aggressive on definition, labels people as hypertensive as 180/30, but slightly more conservative on target, that is ceiling should be less than 130/80. Europeans say it should be can achieve less than 120/70 also, or however an ideal range of 120 to 129 systolic BP. So which philosophy is right for the patients? I think at the end of the discussion we will come to this conclusion. So Team ACC, we talked about normal, elevated, and key takeaways, the hypertension diagnosis is formally applied at 130/80. Team ESC, the hypertension diagnosis is reserved for greater than 140 by 90 millimeters of mercury. They have removed the term like stages of hypertension. Once greater than 140 by 90, the patient is classified as hypertension. So now if you see a patient and he has a blood pressure of 136 by 86 millimeters of mercury, so according to ACC, he would be a stage 1 hypertensive, and ESC he would be still in the range of elevated blood pressure. So does the ACC label of hypertension promote earlier intervention and risk awareness, or does it lead to over medicalization and patient anxiety? So that was the critical debate between the ACC and ESC. Many of the scholars do prefer that the ACC overtreats the patient. So both guidelines are now aggressive on using out of office BP measurement to confirm the diagnosis. ACC recommends home BP monitoring HBPM paired with team based care to improve blood pressure control, and ESC recommends out of office blood pressure either home based or ABPM for all diagnostic purpose to rule in and out white coat and masked hypertension. So these are the ESC guidelines. So talking about scoring, one uses the prevent score, other use the score 2. In the initial guidelines, ACC 2017, they have used the pooled cohort equation. Now they have come with the prevent score because there is a recent data from 3.2 million US population. It has a better calibration, and again the broader outcome because now it includes the MI, stroke and heart failure and not just the ASCVD. So it predicts the total cardiovascular disease. And another aspect in this prevent score that it also takes into the consideration of CKM health. It includes EGFR and even the socio-economic status of the patient in the scoring system. You can put his zip code and it will take into consideration. Now ESC uses the score 2 used for 10-year fatal and non-fatal CVD risk in ages 40 to 69. Score 2 OP for older person, and score 2 diabetes for patient with diabetes mellitus. So ESC handles factors like CKD, hypertension mediated organ damage, diabetes mellitus, familial hypercholesterolemia and social deprivation as a high risk condition for or risk modifiers that up-classify a patient rather than integrating them all into one score. So the number high risk is critical, and ACC 2025 defines high risk as a 10-year score of prevent greater than 7.5, and ESC defines high risk as a 10-year score 2 or score 2 older population greater than 10%. So one says 7.5, other says 10%. Debate points: if you uses the ACC new threshold and new calculator, I may capture a different high risk population than ESC 10% threshold. That is why it is believed that ACC overtreats the patient, and it is beneficial especially in patients with high risk group. So now taking into consideration ESC, very straightforward: blood pressure greater than 140/90, start medication. ACC, if patient is high risk, start. If low risk, that is score is less than 7.5, 3 to 6 months trial of lifestyle, and if BP is still high, starts medication. So we talked about ESC, blood pressure. If it is in the range of 140/90, they straight away say start the therapy. If the patient is having blood pressure elevated range and he is high risk, you should give 3 months of lifestyle, and if still BP is not achieved, start medication. If low medium risk, start lifestyle measurement only. So both the guidelines actually do converge on one thing, that is lifestyle modification to be given, which includes weight reduction, DASH diet, low sodium intake, somewhat increase intake of potassium, and avoidance of alcohol and smoking. So now taking into this patient, and if you see this patient as an example, a 55-year-old guy with a blood pressure 136/88, no comorbidities, 10-year risk of 8%. If you see with ACC, he is a stage 1 hypertension, risk is 8%, start medication along with lifestyle. If you see ESC guideline, he will be in the elevated blood pressure, the risk scoring is still less, start lifestyle therapy. So that is the reason we say that ACC overtreats. So new target, team ACC maintains a clear universal goal, overreaching target for all adults. The team ESC new more intensive ideal target, and the recommended target systolic blood pressure range is 120 to 129 for most adults. Debates embracing the sprint data, because everything has been taken, most of the guidelines from the sprint data, which showed that lowering the blood pressure to less than 120/70 achieved a more favorable outcome. So still a debate. So the crucial fine print, Alara principle says that if blood pressure target is not tolerated, as low as reasonably achievable should be the target, and lenient target are there in the ESC for a patient with symptomatic orthostatic hypertension, individual tailor-made approach to be considered, especially in elderly frail patients. So what about diastolic targets? ACC less than 130/80, ESC says go further low. However, if systolic blood pressure is at goal but diastolic blood pressure is still 80, they give only a weak class 2B recommendation to consider intensive treatment. So ESC is overwhelmingly SBP, systolic blood pressure based guideline. So now this is where they both converge, the supporting of single pill combination. ACC says for stage 2, start with 2 first line agents. For stage 1, they say initiation with single agent is reasonable. ESC is more aggressive and recommends combination therapy as initial therapy, monotherapy only for low risk and especially for elderly and frail patients. First, like they both converge, either thiazides with long acting dihydropyridine CCBs, ACE inhibitors, or ARBs. Only thing is, ACC says that beta blocker can be given in compelling conditions, and ESC says beta blocker should be given in compelling conditions. Resistant hypertension, both guidelines agree on the fourth agent of choice. ACC recommends addition of an MRA in patient with uncontrolled resistant hypertension, and ESC again says MRA if not controlled, add spironolactone, if not tolerated, eplerenone or another agent. So again ACC 2025 says start 2 drug if stage 2 hypertension, target less than 130/80. ESC is very simple, BP greater than 140/90, start a combination single pill combination therapy. Talking about renal denervation, which is making inroads into the guidelines, ACC gave a 2B recommendation that RDN may be reasonable in patients with resistant hypertension despite optimal treatment and patients with intolerable side effects to medication. ESC again class 2B may be considered with resistant hypertension and with increased CVD risk and uncontrolled hypertension on less than 3 drugs who experiences a preference for RDN. Both mandate multidisciplinary team evaluation and shared decision makings. So ACC 25 for RDN, the indication is clearly for failure of therapy, resistance or intolerance. ESC more liberal, indication is broader, again class 2B recommendation, and includes patient preference even before true resistance appears. Debate point, is RDN a last resort or patient preference program? This is crucial discussion for the upcoming cardiologist and interventionist. So the specialist workup for primary aldosteronism, both guidelines are significantly more aggressive on screening for primary aldosteronism. ACC says class of recommendation 1 recommends screening in all adults with resistant hypertension regardless whether or not hypokalemia is there. ESC class 2A, even broader, recommends screening in all adults with confirmed hypertension. So now with these two guidelines, the debate is screening in all patients as per ESC is cost effective or feasible or not, and screening resistant patients seems to be more practical. So lightning, finally key updates, pregnancy, both guidelines now recommend treating chronic hypertension, target less than 140/90. Cognition, class 1 recommendation to target blood pressure less than 130 to prevent cognitive impairment. Chronic kidney disease, class 1 recommendation to use SGLT2 inhibitors in ESC guidelines, and again in heart failure with preserved EFs, SGLT2 are class 1 recommendation in ESC guidelines and not mentioned anything in ACC guidelines. So this is nutshell the targets, risk calculator, threshold, treatment, initial drug therapy, and other RDN indication. So the great convergence, aggressive targets, both guidelines inspired by Sprint, STEP and SPRIT are now pushing for intensive BP control. Single pill combination monotherapy both converge, and new tools have now formally incorporated RDN as the legitimate tool. Final debate, Team ACC, they identify risk earlier and use a more holistic risk approach, and BP target is clear, achievable and evidence-based ceiling. Team ESC, they avoid over medicalization, elevated blood pressure, but for true hypertension, ESC set a more ambitious sprint like ideal targets and are more aggressive with single pill combination therapy. So, in the end, if we summarize, both guidelines signal a new era of intensive hypertension management. The focus has shifted from if we should treat to how aggressively we should treat. And for us as cardiologists, the key is to embrace single pill combination therapy, screen for secondary causes, and consider new tools like renal denervation in our high risk and resistant patients. So, simplicity is the ultimate sophistication, and all for one and one for all is not the therapy. Thank you. Thanks a lot.
Thank you, Dr. Abhishek, for very nice presentation.
Thank you, sir.
So, what I feel is the crux or take-home message is to start medication if the BP is more than 140 by 90,
Yes, sir.
and if the BP is more than 130 by 80 plus any risk factor,
Yes, sir.
high risk patients. But the target should be below 130 by 80
In Asian
each and every.
yes, sir.
Yes.
In high risk
So-
patient, you should achieve in all patient the target should be less than 130
Target
80,
is
either
same.
lifestyle intervention or pharmacological therapy, whatever the patient and we as a comprehensive approach we can take.
Thank you. Any other question?
So, as a cardiologist, I would like to take your opinion about this new concept of ambulatory blood pressure monitoring, which you get to see a lot. I mean,
Uh,
how relevant is it for you?
Very good question, ma'am. ABPM, we do it right here also. It's a very easy test and available everywhere. The only thing difference is some cumbersome, procedure because the patient has this therapy, this ABPM band in situ. But the best part is for white coat hypertension, it is the best therapy for resistant hypertension and for drug adherence. Sometimes you are giving three drugs and the blood pressure is not getting control. So adherence to therapy is very important, and that can be achieved with ABPM. So these are the three classical indication for white coat hypertension, for treatment failures or adherence, and for again resistant hypertension. So that is the thing.
Thank you, Dr. Abhishek.
Thank you, sir. Thank you.
So